I'd like to call this hearing together. I'm very pleased to be the co-chair along with my distinguished colleague that we shared time on the Judiciary Committee together, Senator Grassley. Please, everyone, know that you're very welcome. This is fondly called the Drug Caucus of the Senate. The more formal name for it is the United States Senate Caucus on International Narcotics Control, but it's become the Drug Caucus. And so we are in the process, just for your information, of putting out two reports. One will be on Mexico and the cartels, and the other on Afghanistan and the poppies. But in the meantime, there has been a great deal of concern about methamphetamine. Methamphetamine has been something that those of us up here have tried to work on for a substantial period of time. And I think I introduced the first bill in 1996 with Senator Hatch, and then subsequently a bill later on with the Combat Meth Act with Senator Talent, who was then in the Senate. And so we have watched the situation very, very carefully. It is clear that the situation has not abated, however. Illegal drug manufacturers have found ways to circumvent the laws passed by this government. And now today they send out individuals known as smurfers, people who go from store to store purchasing packs of cold medicines. Now, these cold medicines contain pseudoephedrine, and they can be popped right out of the blister packs through various machines, just bing, 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 and cooked into methamphetamine. These smurfers, we have learned, are organized. They are deployed throughout commercial districts and shopping centers to make purchases within the lawful limit. Some of them carry fraudulent identification. In 2006, Oklahoma deployed the first system to electronically track pseudoephedrine purchases, followed by Arkansas and Kentucky. However, these tracking systems are increasingly ineffective as the pseudoephedrine smugglers find ways to counter them. The director of the Kentucky Office of Drug Control Policy told my office that since Kentucky initiated a statewide tracking system in June of 2008, electronic tracking has not had the prevention effect they hoped it would. In fact, in 2007, the year before the electronic system was deployed, Kentucky reported 309 labs. In 2008, they reported 427, and in 2009, 716. So these electronic tracking systems have not reduced meth labs over the long run in the states where they have been deployed. I was mentioning to Mr. Kurlikowski and Dr. Granley when I came in that I spent some time in Fresno with state, federal, and local law enforcement, including the United States Attorney in Fresno. And what they pointed out to me was rather chilling. We had a 27-year veteran of the Los Angeles Police Department actually show us 96 pages of fraudulent tracking. And he also, just for the purpose of this, these are all fraudulent California driver's licenses. So the smurfers, when they go out, they have a fraudulent driver's license. And they present that at the druggist. They sign a name that is virtually undecipherable. I looked at pages of them. And they buy the product, and let's say for $6, $7 worth of cold medicines, they turn them in, and they pick up $30 or $35. The vans go out, and they just cover malls, commercial areas, people spread out. They pick up the products, they go in, they get their money, and the pseudoephedrine is pumped right out of the pill. The detective that we worked with was a retired Los Angeles Police Department and LA Impact meth team detective Rick Gutierrez. And he said specifically, the tracking system does not block illicit sales because multiple and fraudulent IDs are a big problem. He also said that it would take the entire Los Angeles Police Department just to be able to track smurfing going on in Los Angeles. The California Bureau of Narcotics Enforcement estimates that at least 50% of pseudoephedrine sold in California is being used for the illicit manufacture of methamphetamine. So at least 50% of the sales are essentially for illegal purposes in my state, I'm sorry to say. I'm not going to take any more time, but I do want to welcome to our panel Senator Wyden. Senator Wyden hails from the state of Oregon, and Oregon has been the state that essentially has totally put cold medicines behind the counter, subject to prescription, and had some amazing results. I'm not going to tell you what they are. I'm going to leave it to him to do. But he's going to sit with the caucus today, and I will call on Senator Grassley next and then ask you to make a statement, Senator Wyden, and then introduce the first of two panels. And we're very pleased to have both of our witnesses here this morning. So if I might call on my co-chairman, Chuck Grassley.
Thank you very much. What I'd like to do before I give my statement is to have inserted in the record testimony, I won't name, but three national organizations from about 3 attorneys generals and other letters, including one from Representative Henry Waxman of your state, and then resolutions from Sheriff and Police Association and National Sheriff's Association and Central Florida, North Florida, HIDA. Could I please have that done?
Absolutely.
And then,
so ordered.
Then for people that tend to be cynical about all of the partisanship in Washington, I want to say something ahead of time, because Senator Wyden has been so deferential to me on this issue, and we may come out at different ends of the issue, but for months he waited for me to study the bill and give him some answers, and we were tied up with some other things. But you're one of the easiest persons to work with on Capitol Hill, and I thank you very much for the deference you gave me on this issue. Thank you. Madam Chairman, I really appreciate holding a hearing on methamphetamine and our continued effort to remove this terrible drug from our streets. Meth is devastating. A drug that destroys lives and families and communities. Midwestern states such as my state have been hit especially hard by meth. The impacts of this drug have been devastating in rural areas. As opposed to other illegal drugs, meth is often home cooked and made in rural areas using ingredients that are largely available over the counter. Congress has taken action to attack this problem. Legislation such as Combat Meth Act, which our distinguished chairman and I co-sponsored with Senator Talent when he was still in the Senate, is a big reason domestic meth labs are down. But the result of combat meth were felt almost immediately, and labs across the country began to fall. Now, however, there's a negative. The decline in domestic meth labs has begun to level off, in some areas even increase. The common thread among these meth labs is the way cooks obtain the main ingredient PSE through a process known as smurfing. It occurs when a person visits a number of different locations to buy the product, the ingredient. The result is an amount of PSE sufficient to produce home-cooked meth. Last Congress, I joined Senator Durbin authoring Methamphetamine Production Prevention Act, which made it a federal crime to smurf PSE products across state lines. It also modified the Combat Meth Act to allow retailers to maintain the logbook information in electronic format. these two changes were necessary to combat smurfing, but more work needs to be done. Today's hearing is designed to look at the problems of increasing domestic meth production and what can be done to stop new labs from popping up. One proposal comes from the state of Oregon, where the legislature passed a law requiring individuals to obtain a prescription from a doctor in order to obtain products containing PSE. This is a proposal that advocates say will help reduce domestic meth production, but others argue that this approach reduces patient access to PSE, raises health care costs, and may hinder law enforcement in locating and preventing meth labs. While Oregon and Mississippi are the only states to pass a law requiring doctor prescription, many other states have taken different approaches to combat smurfing. My home state of Iowa has been a leader in taking proactive steps to cut illicit supply of PSE. For example, Iowa PSE products can only be purchased from a pharmacy and not through convenience stores, effectively limiting the supply to professional pharmacists. Iowa has also followed the example set by a number of other states and passed legislation requiring real-time electronic tracking. A federal grant program to create a pilot version of electronic tracking was included in the original legislation Senator Durbin and I introduced. While the federal grant program did not ultimately make it into final bill, I still believe that our electronic tracking works seamlessly. We need to examine the idea of expanding it nationwide. While it may be too early to tell full results, many states that have implemented real-time tracking have experienced success. The witnesses here today will discuss Oregon's experience with making PSE a prescription-only drug, as well as other states experiencing with electronic tracking. I have concerns about the approach Oregon has taken. We need to strongly consider the economic impact this proposal will have if it is implemented at the federal level. For example, to obtain a prescription, individuals would be required to visit a doctor. That visit will increase costs to the consumer, including the cost of the visit, insurance co-pays paid by the consumer, and increases in insurance premium to cover the cost of doctor's visit. Further, there is no real experience in changing a product from over-the-counter to prescription, so it's also unclear if consumers will experience increased costs for the product. Taken together, these new costs could significantly impact millions of Americans that use PSE annually. Also, I'm concerned with the proposal to schedule PSE based upon concerns raised by law enforcement. For example, an October 30th, 2009 article in the Portland Tribune discussed the meth problem in Oregon following the new law. The article quoted Matoma County Sheriff Deputy as saying, there is a lot more meth than ever than there ever was before, end of quote. The same article quoted Portland Police Bureau officer who said, there's so much, it's ridiculous. The article continues, Oregon's legislative changes contributed to a radical transformation in the underground meth economy, one that in some ways is making the problem even more difficult to fight, end of quote. Another Oregon paper wrote an editorial citing police sources saying that following the passage of the law in Oregon, meth labs are down, but meth use has remained consistent. The same editorial also discussed how many residents of Oregon who purchase PSE products simply obtain it by traveling to Washington State to make the purchase. In fact, anecdotal evidence has suggested that sales of PSE products in neighboring states has increased 6 times since the prescription-only law was passed. Taken together, these two articles raise a number of questions about what the true cost of the federal law requiring prescription to obtain PSE would really be, both in terms of economics and law enforcement. So I look forward to the testimony and continued discussions with my friend Senator Wyden and Senator Feinstein.
Thank you very much, Senator Grassley. I'll now turn to Senator Wyden and then introduce the panel.
Thank you very much, Madam Chair, and thank you for all your leadership. I don't believe anybody in public life has prosecuted this fight against drugs the way you have, Madam Chair. Not just meth, but generally the fight against drugs. So I'm very, very appreciative of all the time that you've given me on this issue and your leadership, both in passing the federal legislation and on a host of other anti-drug efforts. And as far as the gracious comments of my friend Senator Grassley, I'm of the view that Senator Feinstein and Senator Grassley give bipartisanship a good name, and frankly, the two of you ought to be put in a copier or something and get some more people in Washington, D.C. to pick up on the Feinstein-Grassley example. And I want to thank Senator Grassley for all the time that he's given me as we've discussed this issue. Chairwoman Feinstein, you've made so many of the important arguments so well. Let me just try to highlight a few of the key issues and try to set the record straight with respect to some of the particulars about this issue. When Oregon debated going to the approach we put in place, a prescription for pseudoephedrine, at the Oregon legislature, opponents of the bill advanced what amounted to a parade of horribles. The state legislators were told that just about everything awful in Western civilization would descend on Oregon if we passed this law. We were told that prices would go up. We were told people wouldn't be able to get their medicine. We were told people would be subjected to god-awful inconveniences of every size, shape, and form, and none of it has happened. And let me put on the record an example that I think would be relevant for folks in Iowa. Senator Grassley has long had town hall meetings in every county every year in the state of Iowa. He's got a lot more counties than I do, but I've got a lot of counties too. And since the passage of this law, there has not been one single complaint at my town hall meetings about this law. I've consulted with state legislators as well. They have not had the complaints either. So as we listen to this debate, and I think it's important to do exactly what Senator Grassley said, which is to get into the specifics and how folks are affected, I want to set on the record that every one of these horrendous consequences that we are told will affect people in all parts of the country if the nation goes to a Oregon-type approach to meth. Every one of those arguments was advanced in my home state in great detail, and we have not seen the problems. And part of this is just getting the story out. The pictures that Senator Grassley showed apparently are from an article that was written shortly after the law was passed. So the evidence, for example, as presented by Oregon law enforcement officials is now very different. For example, since the law has been enacted, we have gone to a significant reduction in the number of meth labs. In 2009, Oklahoma had 743 meth labs. Kentucky had 741. Arkansas had 643. Oregon had 10. Now, with respect to law enforcement, the mention was made in connection with that article. There's a relevant point as well. When I announced that I was going to work with colleagues on a bipartisan basis in Washington, D.C. to take the Oregon model nationwide, when I made that announcement, law enforcement officials from across the state lined up to say, we need this legislation, we are going to be behind you. So any suggestion that Oregon law enforcement is not overwhelmingly behind this approach, taking the Oregon model nationwide, is simply not accurate. I see my friend John Kroger, Oregon's terrific Attorney General, in the audience. He will be laying out the case for why he and law enforcement officials in our state are overwhelmingly in favor of this approach. A couple of other points, and then I think we ought to move on. First, Oregon has tried the kinds of approaches that other states are still testing. For example, legislators in Oregon said, well, let's look at putting PSE behind the counter, requiring the log books, limiting the purchase to, in effect, try to test that kind of system. What happened when that was tried is a group of Oregon legislators went out and did their own smurfing operation as an experiment, and they themselves found that it wasn't working. Under that kind of approach, they could go out and buy enough PSE to cook a bunch of meth, and certainly with the phony IDs that our chair has advanced, you see further evidence of it. One last point, if I might, Madam Chair. In 2009, the crime rate in Oregon dropped by 10.6%. I've been one to say that it is never possible to attribute a drop in crime to just one factor alone, but the Oregon Criminal Justice Commission pointed to our law requiring that PSE be by prescription, that was a major factor in the decrease that we have seen. So I look forward to our testimony and our witnesses. And again, I urge legislators and those who are following this debate to look at the arguments made by the opponents, that the policy will hurt legitimate consumers, people will experience higher costs, doctors will be overwhelmed by appointments, pharmacists will be in revolt. I ask, show us the evidence. I don't believe you can put the evidence on the record. We would all agree the scourge of meth is not a partisan question. When you visit these homes that practically look like Superfund sites, nobody is going to ask, is this a home that has a Democrat or a Republican in it? They want to see what's going to be done to control this horrendous scourge. I look forward to working with my colleagues, our chair, and Senator Grassley to look at all of the possible tools to deal with this public health and public safety menace. And I thank, again, our chair for scheduling this important hearing.
And I thank you, Senator Wyden, for those very cogent and strong comments. They are appreciated. I'd now like to introduce the first panel. I'd like to welcome Mr. Gil Kurlikowski, who is the Director of the White House Office of National Drug Policy. Mr. Kurlikowski has 37 years of law enforcement and drug control experience, most recently serving 9 years as Chief of Police of Seattle. His distinguished career at both the local and federal level have led to numerous awards for leadership, innovation, and community service. The second speaker on this panel, and we've put them together to have two panels, Mr. Kurlikowski has to leave early, so we'll question you first at the appropriate time. But I'd also like to welcome Dr. Charles Ganley, who is the Director of the Office of Non-Prescription Drug Products, the Center for Drug Evaluation Research of the United States Food and Drug Administration. Dr. Ganley has 15 years of experience with the Food and Drug Administration. In his current capacity, he monitors non-prescription and over-the-counter products at the FDA. In his role at FDA, he frequently presents to industry and academia on topics such as risk management and monitoring of over-the-counter drugs, expanding the over-the-counter drug access and the future of such products. So, gentlemen, we welcome you both here. I'd like to put two letters in the record. One is from Steve Six, the Attorney General of the state of Kansas, and the other is Richard L. Harris, the Interim Assistant Director of the Oregon Department of Human Services. So now we'll proceed. Mr. Kurlikowski, welcome, and please go ahead.
Thank you. Thank you, Chairman Feinstein and Co-Chairman Grassley. Having a long time in law enforcement, I want to personally...
Is your mic on?
It's on red.
Yeah, pull a little bit closer to yourself.
How about now?
Much better.
Okay. I want to also thank you, having a long time in law enforcement personally, for your advice and counsel from both of you, not only to me, but to my colleagues across the country, and for your strong support for law enforcement and your strong support on the issues surrounding the drug problems in this country. It is truly respected. The Obama administration understands that addiction is a disease, that law enforcement, prevention, and treatment must all be included as part of a comprehensive strategy to ensure public safety, to stop drug use, and to get help to those who need it. We will soon release the President's 2010 National Drug Control Strategy. And this inaugural strategy commits the Obama administration to reduce drug use and its consequences. The public safety impact of drug use is dramatic, and the public health consequences of drug use are equally enormous. Drug overdoses now outnumber gunshot deaths in America. They are in 16 states ahead of vehicle crashes as a cause of fatalities. Whether being a victim of a drug-related crime, struggling with addiction, or worrying about a loved one's substance abuse, millions of people in this country live with the devastating impact of illicit drug use every day. And this stark reality demands a new direction in drug policy, one that is based on common sense, sound science, and practical experience. Right now, today, we're addressing very specifically the issue of methamphetamine, an important aspect of our entire national drug control effort. This very highly addictive and illicit drug has affected the lives of millions of Americans. Let me begin by saying that ONDCP, the office that I now manage, was late to recognize the meth problem. And as a result, Congress criticized the office to the extent that specific direction was provided to us. During my tenure, we will remain focused on this problem, and we will ensure that that does not happen again. Meth continues to be a problem in many parts of the country, and a more stringent law enforcement response, effective prevention and education campaigns, and the Combat Methamphetamine Epidemic Act have helped to reduce the problem, but quite frankly, more must be done. From 2006 to 2007, the government of Mexico's restrictions on precursor chemicals severely disrupted Mexican production capabilities, and as a result, United States production and distribution networks grew to meet domestic demand for the drug by avoiding the precursor restrictions imposed by the Combat Meth Act. This growth in domestic production is largely attributable to the increased numbers of the small-scale meth labs throughout the country. These labs and their associated distribution networks are organized particularly by individual or small-scale criminal groups running organized smurfing operations. These smurfing operations use individual purchasers to acquire illegal quantities of precursor chemicals through multiple purchases from retail locations. And as a police chief, I recognize that the meth lab discoveries created huge problems within a community. The array of dangerous chemicals used in the meth production process creates a dangerous and very often unstable environment, posing severe environmental risk, fire, etc. Perhaps one of the greatest concerns associated with clandestine meth labs is the presence of children in these dangerous environments. It is also extremely expensive, and it is very labor-intensive to train, certify, and equip personnel to respond to these incidents. Meth is complicated and it's horrific, not just for what it does to those who use it, but also because it is so easy to manufacture. High-quality meth is made right here within the borders of the United States, and the effects on rural and suburban America are quite serious. The administration supports several important efforts now to combat meth production and trafficking, and to prevent its use and to treat those that have been affected by it. The administration is committed to working with the criminal justice system to reduce meth-related crime and improve public health and safety. Recovery from methamphetamine can work, and I have literally met dozens of people that are in recovery. It requires resources. Oftentimes, those resources include expensive medical and dental care also. Facing a familiar threat from domestic lab production, the state of Oregon in 2006 returned pseudoephedrine to the prescription drug as it was prior to 1976. In Oregon, there was a lot of debate about whether the law would prevent smurfing in meth labs, whether there would be a public outcry or other adverse consequences. Well, now, nearly 4 years later, the results are very encouraging. Smurfing within the state has been significantly reduced, and the dramatic reductions in meth lab incidents have been reduced. Meth-related arrests have decreased in Oregon, and this approach should be closely examined to ensure that law enforcement, public health leaders throughout the country have the best tools available to effectively address the threat of growing domestic production. In addition to Oregon, Mississippi, and cities in Missouri have also produced legislation of a similar nature. And as a former law enforcement officer, I know that there is strong support among the law enforcement community for what has occurred in Oregon. Now, over the years, I've met hundreds of victims, and they appreciate law enforcement, they appreciate a quick response, and they appreciate it if we get their property back. But if I ask them, would you rather have the crime prevented? Well, I think you know what the answer is. That is what Oregon has done. They prevented the crime. Methamphetamine poses a significant challenge for policymakers. It is also extremely labor intensive, and in talking to all of my former colleagues in my former profession, they have neither the time nor the resources to utilize the tracking system, especially when it has so many loopholes that are already in it. Thank you.
Thank you, Mr. Kurlikowski. Chair would like to recognize Senator Udall. Senator, do you have any comments you wish to make, or? Well, thank you very much for being here. We appreciate it. And now we'll go to Dr. Ganley from the FDA.
Good morning, Chairman Feinstein, Co-Chairman Grassley, Senator Wyden, and Senator Udall. I'm Dr. Charles J. Ganley, Director of the Office of Drug Evaluation for the Food and Drug Administration. The office that I oversee is responsible for the regulation of...
Your mic on, Doctor?
Yes.
Pull it a little closer so that...
For the regulation of over-the-counter or OTC drug products. Thank you for the opportunity to discuss the drug pseudoephedrine. Pseudoephedrine is a drug found in many OTC products and is used to relieve nasal or sinus congestion caused by the common cold, sinusitis, and respiratory allergies. Pseudoephedrine is also found in prescription products combined with prescription-only drugs. In this testimony, I would discuss how pseudoephedrine products are currently regulated by FDA, the primary differences between pseudoephedrine and other drugs used to treat nasal congestion, and the potential impact of a change in access to OTC products. All prescription pseudoephedrine drug products and some OTC pseudoephedrine drug products are subject to FDA's new drug application process. The majority of OTC pseudoephedrine drug products, however, are regulated under a different regulatory process, the OTC drug review. In January 1972, FDA began the OTC drug review, or the OTC monograph, a program to regulate OTC products that had been introduced to the marketplace prior to that time. This program determines which OTC drugs can be deemed generally recognized as safe and effective. And I'll use the acronym. The acronym for that is GRASE, and we usually refer to that as GRACE. Products marketed under an OTC monograph are not subject to FDA approval prior to marketing, as long as they comply with the OTC monograph and other relevant FDA regulations, such as good manufacturing practices. The OTC monograph for nasal decongestants covers several decongestants, including pseudoephedrine, in various dosage forms. Near the onset of the OTC drug review, FDA convened an advisory panel of clinical experts to evaluate the existing safety and efficacy data for OTC cold, cough, allergy, and bronchodilator drug products, including pseudoephedrine. FDA reviewed submitted comments and other information received in response to its advanced notice of proposed rulemaking and tentative final monograph. And in August of 1994, we published the final monograph for nasal decongestant drugs. Manufacturers were given an effective date at which time their products were required to be in compliance with the final regulation. On March 9, 2006, the Combat Methamphetamine Epidemic Act of 2005 was signed into law. Congress passed this law in an effort to reduce the illicit manufacture of methamphetamine. The law requires, among other things, that all sellers must place pseudoephedrine products where customers do not have direct access to such products before a sale is made. Nevertheless, even though pseudoephedrine products are now available, quote, behind the counter, FDA still defines pseudoephedrine as an over-the-counter drug in accordance with the monograph and FDA regulations. An OTC drug is a drug whose use does not require oversight by a healthcare professional. The OTC nasal decongestant monograph currently includes 2 GRACE decongestants for oral administration, pseudoephedrine and phenylephrine. Like pseudoephedrine, phenylephrine was subject to the OTC Drug Review Panel review and subsequent notice and comment rulemaking process. Data comparing one drug to another are not required for FDA to make a GRACE determination for a drug in the OTC Drug Review. No comparative claims are covered by the OTC monographs. However, the proliferation of OTC products formulated by manufacturers with phenylephrine following the enactment of the Combat Methamphetamine Epidemic Act of 2005 gave rise to increased public interest in the adequacy of phenylephrine as a more accessible alternative to pseudoephedrine. In December of 2007, FDA held a public advisory committee meeting to review the current safety and efficacy data for phenylephrine. Members of the Non-Prescription Drugs Advisory Committee largely agreed that while additional studies would be useful to evaluate higher doses, the 10 milligram phenylephrine dose currently included in the OTC monograph is effective. Pseudoephedrine and phenylephrine differ in duration of action, so that it is recommended that pseudoephedrine be taken every 4 to 6 hours, but phenylephrine with a shorter duration of action be taken every 4 hours. FDA considers both pseudoephedrine and phenylephrine as safe and effective for their intended uses. The monograph also includes 8 nasal decongestant ingredients that can be applied topically into the nasal passage either as an aqueous solution, for example in the form of a spray or using a dropper, as a water-based jelly, or as inhaled into the nasal passage. The rate of application can vary from every 2 hours for an inhaled product to up to every 12 hours for sprays and jellies. Any additional measures restricting the sale of pseudoephedrine to reduce the likelihood of product misuse must be balanced with the need to maintain access for legitimate and safe use. Having access to different ingredients without the need for obtaining a prescription from a healthcare professional allows consumers to obtain medications quickly and will not delay access to symptomatic benefit. Individuals respond differently to medications, some getting more benefit from a specific ingredient than others. Additional consideration should be given to the idea that requiring a prescription could increase healthcare costs for those who prefer pseudoephedrine. As the Office of National Drug Control Policy Director, Gil Kurlikowski, has testified, pseudoephedrine continues to be misused to illicitly manufacture methamphetamine, and there are important public safety reasons why additional measures restricting the sale of pseudoephedrine may be appropriate. Thank you very much for the opportunity to testify today, and I welcome your ideas and questions.
Thank you very much. Mr. Kurlikowski, I have a good deal of frustration because in beginning this effort in 1996, largely by restricting the precursor chemicals, we find that then they began to come in another way, that every step, every bill has been met by action to essentially obfuscate the impact of the bill. And meth, which began to go down, is now apparently the meth labs are increasing throughout the United States. The last combat meth bill is over at the House, passed the Senate, it's waiting action in the House. That refines the tracking somewhat. But the question comes, really, and I want to just put it to you directly, whether we should proceed to take the Oregon model and make it a national model. My understanding is the Oregon crime rate has dropped rather dramatically. I think it's 10% or more. That the people of Oregon seem very satisfied with it. That it has clearly reduced the number of labs to, is it 10? 10. To 10. So the question comes, is it an appropriate model to become a national model? So may I put that question to you, please?
Sure. There are two important issues. One is that methamphetamine is not a significant problem in outside of about 20-plus states. Not that it doesn't exist, but we certainly know from our experience in the West and certainly now in the Midwest and the South in many places, the very significant problems. When I visited the New York City Police Department, one of the Midtown precincts, I could have put meth on the table at roll call, and I'm not sure anyone would have recognized it in Midtown. So I think you have to examine very closely the fact that there have been vast improvements in what I've seen in the West and in Oregon as a result of what they have done. I think you have to then think very carefully, is this a model that can be extended to the entire country? And if so, what are the ramifications? But when I spoke with Governor Barber in Mississippi, and after he had examined all of the evidence, and he kind of looked at me and said, well, you know, it's just the right thing to do. So
what is your answer to the question?
So since the bill has not been introduced, and the administration will take a position on the bill and a statement of position, I would like to defer until the bill is introduced. But I am strongly encouraged by what I saw in Oregon, and I think there is every reason to believe that what they have done has been effective in protecting people and reducing the problem significantly.
Right. It is a problem in California, a big state with very big labs, generally run by Mexican nationals. Sophisticated, the smurfing operation is huge, and the amount of illicit sales, according to the State Bureau of Narcotics Enforcement, is 50%. So that means half, despite tracking, of everything that's sold is used to produce methamphetamine. I'm very dedicated on this cause. I've started, I'm going to finish it one way or another. So the question comes, perhaps California should on its own pass a law. That was before the state legislature. It passed one house. It lost by one vote in the Public Safety Committee. And it's very hard for me to see what's happening in the state with meth, and nothing is being done about it, essentially. And it's taking huge amounts of law enforcement time, which is another problem. And with methamphetamine come increased emergency room admissions, real problems with behavior, real, dramatic addiction. I mean, it is a bad drug. People have done bizarre things taking methamphetamine. So I appreciate the fact that you want to wait till there is a bill. I did want to try in any event. Dr. Ganley, you spent some time discussing what's called on the street PE, which is a cold medicine that has in it phenylephrine, which I gather is not pseudoephedrine, and doesn't have the qualities that pseudoephedrine has in terms of using it illegally. Can you comment on how effective it is as a cold medicine?
Well, this issue was raised, as I mentioned in the testimony, at a December 2000 advisory committee. We received a citizen's petition that had reviewed the information that was used by the early panels to look at this information, and they came to the conclusion that the 10 milligram dose of phenylephrine was not an adequate dose. There also were some additional studies that had been published where phenylephrine had been compared to placebo, and pseudoephedrine had been in those studies also. Pseudoephedrine beat placebo and phenylephrine did not. The committee looked at all this information, and approximately about half the studies that were looked at from the early years when the original monograph was developed showed it wasn't effective. So
it was or was not?
Was effective.
It was as effective?
No, we don't really have great comparative data. And again, I think what their conclusion was is that the 10 milligram dose is probably at the very low end of a dose response. And they suggested that we look at higher doses.
I see. So is it correct that what you're saying is that you don't know, that the dose needs to be a little bit higher to be comparable?
Yeah, I think it's difficult to try to compare different medications. Generally, when you do clinical studies looking at effectiveness, you generally, if you're going to do an adequate comparison of the two ingredients, you have to really look at a dose response for each ingredient relative to each other. We don't have that data. And as I noted in my testimony, we don't really require that data. We don't make comparative claims in the monograph. I think the concerns of the committee when they looked at phenylephrine back in 2007 was that in the populations that were enrolled in the clinical trials weren't very diverse. There weren't a lot of people enrolled, and they had suggested that additional studies at higher doses be evaluated. Now, the downside with these category of drugs is that as you go into higher doses, you get into issues related to elevations of blood pressure and heart rate, which can cause potential adverse effects in some individuals. And so in the future, we need to look at this issue. We need to have this higher dose evaluated and see what the pure dose response is for phenylephrine. But right now, the 10 milligram dose meets our definition of generally recognized as safe and effective. Let me just make one other point regarding, and this is more from a clinical point of view. And I think all of us have experience with different drugs, not just decongestants, but antihistamines. Some respond better to one drug versus another. There's really no rhyme or reason. And generally, people will stick with a particular drug that they find effective, or they'll switch to another one if they don't. And so you're going to have individuals who are perfectly fine with phenylephrine and others who don't respond to phenylephrine and may have a preference for pseudoephedrine.
Thank you. Thank you very much. Senator Grassley.
Chairman. Director Karolowski, we have received written testimony about the dramatic drop in meth labs in Oregon following the implementation of the state law. The data supporting this position states that in addition to Oregon, meth lab incidents have decreased significantly in states surrounding Oregon as well. In fact, since 2001, meth lab incidents in Washington State have decreased 97%. They've dropped 90% in California, 94% in Idaho, 97% in Nevada. The data shows that the meth labs have fallen dramatically in nearly all Western states, states that have not implemented prescription-only legislation. Do you agree that other Western states have seen dramatic reductions in meth lab incidents?
I do agree, but I think the most recent data is the more troubling, and that's the increases in other states versus what has happened in Oregon.
Okay. Since we're talking about Oregon as a model, is it your testimony that the meth problem disappeared in Oregon?
No, and I think it'll be very clear that when we're talking about law enforcement resources, environmental hazards, labs, dangers to children, those are the things that have been improved upon and safety has been achieved. This is not a cause celeb for ending methamphetamine problems.
Okay. I'd call your attention to the Department of Justice National Drug Intelligence Center dated June 2008, quote, Oregon's high-intensity drug trafficking area drug market analysis. It reads in part, quote, local production decreased after legislation was passed in August 2005 requiring a prescription to purchase medication containing ephedrine or pseudoephedrine, the precursor chemicals used in production of methamphetamine. As local methamphetamine production declined, Mexican drug trafficking organizations expanded local networks to distribute ice methamphetamine produced in Mexico. This Department of Justice report concludes that, quoting again, ice methamphetamine poses the most significant drug threat to Oregon high-intensity drug trafficking area. I'd ask consent to put that in the record, Madam Chairman, and I have questions. Have you seen this report that I held up here?
I'm familiar with the HIDTA reports that are required from all 28 HIDTAs assessing a drug risk or a threat.
Yeah. Do you agree with the conclusion that ice methamphetamine has filled the market demand in Oregon?
No, I don't. I believe in 2008, when they wrote that report, certainly those were the things to be expected. What has occurred is that as the government of Mexico severely restricted the precursor chemicals, they did go to other manufacturing methods, what's called the P2P method. And, but it should be noted that methamphetamine is less potent than the methamphetamine that we make right here within our own borders. So I think there are a couple important things. I would certainly agree, Senator, that methamphetamine will not disappear. I would certainly say, though, that the information about the decrease in arrests and the improvements in public safety and the efficiency and use of law enforcement resources are worth a very careful examination of what occurred in Oregon.
If the Oregon law were extended nationwide, as some have advocated, how would we prevent glut in the market that can be filled by more violent foreign drug sources of the methamphetamine?
I think we've made great progress on the southwest border. I clearly think that the support of the members of Congress to the Department of Homeland Security, to the Department of Justice, have significantly reshaped the borders, whether it is in human trafficking, whether it is in smuggling, and I look at the number of seizures of all of the drugs that are attempted to be smuggled across the border, and the work that's been done to shut off the flow of cash and to decrease the number of firearms. I would still tell you, with our open border system and 2,000 miles south and 6,000 miles north, that drugs can still be smuggled in.
Okay, Dr. Ganley, your testimony discussed the efficacy of phenylephrine, the substitute ingredient to allergy and cold medicines. The efficacy of PE has been challenged in recent years. In 2006, Representative Waxman wrote to the FDA and enclosed a peer review letter to the editor that was published in the Journal of Allergy and Clinical Immunology by two researchers at the University of Florida. That letter concluded that there is little evidence showing that PE is any more effective than placebo at maximum FDA-approved dosages. FDA continues to stand by the 76 monograph that determined PE as effective at 10 milligram dose. However, others are now calling for new clinical trials to study the efficacy of PE the same way that PSE was studied. And I'd like to put a letter in the record from the British Journal of Clinical Pharmacology calling for new trials. Additionally, Representative Waxman wrote to FDA a second time in 2006 asking the FDA to convene an advisory committee in light of a completed clinical trial sponsored by Schering-Plough. The study compared PE against placebo and PSE for nasal congestion. At the time of his letter, the study was completed but not published. The results of that study were published in 2009 and found that, quote, phenylephrine was not significantly different from placebo, whereas pseudoephedrine was significantly more effective than both placebo and phenylephrine, end of quote. Dr. Ganley, are you familiar with the clinical trial conducted by Schering-Plough completed in April 2006, marked by clinical trial identifier NCT 00276016?
Yes, that information was also discussed at the 2007 Advisory Committee. Okay. When Congressman Waxman sent that letter in 2006, we were aware of the published letter that the author had, published. And in the response to Congressman Waxman, we had asked that the individual who published that submit a citizen's petition. And that's what prompted the December 2007 Advisory Committee. So the Advisory Committee had that information, had the Schering study. They had new information from Schering that was presented at that meeting. And the conclusion of the Advisory Committee was that they did feel that the 10 milligram dose was still an effective dose for some people, not all people, and it is probably at the lower end of the dose response for phenylephrine.
Do you, Dr. Ganley, does the FDA support a nationwide federal law that would schedule PSE as a controlled substance similar to Oregon, and why or why not?
Well, The FDA does have a position right now, and it's still under discussion.
Okay. Do you believe that in light of the clinical trials and this is my last question, the 2006 University of Florida study that the FDA's 1976 monograph should be revisited by FDA?
Yes. The next step for that would be to put out a call for data, which we are in the process of developing, and to proceed from there.
Thank you, Madam Chair.
Thank you very much, Senator Grassley. Senator Wyden?
Thank you very much, Madam Chair. I think it's been a very good panel. Suffice it to say, this is getting hard to follow the blizzard of statistics and the like, and I want to see if I can just kind of isolate what I think this debate is all about. Clearly, we continue to have a major meth problem in a very significant number of states. And there are really two entrants to this debate and two separate tracks for how to proceed. One is the track that argues for what is called electronic tracking. The other is the track that I advocate, which is taking the Oregon approach nationwide. Now, here are the hard, documentable facts for 2009. I think what Senator Grassley and I are kind of having a debate about is the statistics that he's used are outdated, in my view, and I want folks to see the current ones. So in 2009, Oklahoma had 743 meth labs. Kentucky had 741 labs. Arkansas had 643 labs. Those are hard, documentable figures from 2009 with the electronic tracking system. The hard, documentable figures from Oregon, which has put pseudoephedrine as a prescription drug, we have 10 labs. So that's what this debate is all about. Electronic tracking, where I've cited the figures from Oklahoma, Kentucky, and Arkansas that have many, many times the number of meth labs, as opposed to Oregon, which has 10 using the approach that I've described today, pseudoephedrine being a prescription drug. So those are the facts that are documentable on the record for the most recent year, 2009. My question to you, Mr. Kurlikowski, is essentially, I really have two questions for you. The first is, we are still finalizing legislation, and I understand the administration's position, FDA's position, absolutely. So what I think I'd like to see, if we could get on the record, is based on the hard, documentable analysis you've done of the evidence to date, is there any reason, in your view, why the Oregon model could not work nationwide?
No.
Okay. I want that understood because, folks, that's what this debate is all about. Director Kurlikowski has now said, in response to the hard evidence, again, not subject to all the spin of interest groups, that it is his judgment that there is no evidence that the Oregon model could not work nationwide, and I thank you for your clarity and your succinctness. Last question is, you described in your testimony the loopholes in the alternative approach, the electronic tracking system. Could you just amplify on that so we could have on the record what you think the loopholes are?
The loopholes are legion. First of all would be the lack of any type of identification that can be used. I happen to have a staff member that went to purchase some pseudoephedrine for a sinus problem, had no identification, had money in her pocket, but happened to have a letter that had been addressed to her, and the large retail chain drugstore that she went to purchase said, oh, that's perfectly fine, a letter that had been addressed to her at her home as a form of identification. We know how easy it is to obtain these false IDs, and the system does not prevent what is occurring with the false identification. The second, just having been a police chief for a long time and trying to figure out where to put really finite and limited resources, I haven't talked to any of my former colleagues that have a lot of detectives and analysts and, quite frankly, prosecutors sitting around saying, boy, I wish we had more work to do. The first tenet of policing that was formed when Sir Robert Peel talked about policing several hundred years ago was to prevent crime. As administrators, that's actually what we're supposed to do first, is prevent crime. Quite frankly, the Oregon model seems very clearly to have prevented many of these crimes, these labs.
Thank you, Madam Chair.
Thank you very much, Senator Wyden. I would like to put a whole series of letters in the record from various attorneys general, and I just wanted to quickly quote from one, which is signed by John Gaines, the chief of the Bureau of Narcotic Enforcement of the State of California Department of Justice. And he points out in his letter the examples of smurfing in Los Angeles, and I had no idea as to the size of this operation. It is tremendous. He points out how, you know, one CVS store had like 9,000 sales in a couple of days, most of them fraudulent sales. And this was a CVS drugstore chain that began a stop sales program in October of 2008. Within the first hour, CVS blocked 168 purchases of PSE. Over the next 20 days, 9,400 purchases. And an examination of just 11 stores revealed that they sold 16,985 fewer grams of PSE in November than was sold in October prior to the implementation of the block sale. So it's just huge. He goes on Las Vegas, Nevada, and my figures indicate, Senator Grassley, that the number of labs that 2006 appears to be a change year, 2007, I guess. 2007 that began to grow, 2008 they grew. So despite everything we're trying to do, apparently the lab incidents, the dump site incidents, those kinds of things are all now increasing. Mr. Kurlikowski, would you agree with that?
Yes, I would. The numbers show increases in lab incidents, lab seizures, dump sites where the precursors or the leftover packages have been found.
So my point is, whatever we do in terms of bills, and you've tried and I've tried over the years, and we've gotten some through, and one's on the way at the House, it doesn't stop the problem, and the problem continues to grow. Now, if this were a benign addiction, I don't know that there is one, but if it were a benign addiction and people didn't do terrible things under the influence of meth, I would say, well, maybe going national with the Oregon system isn't germane. But people do terrible things. It does spawn other crime. You know, I'll never forget reading, I think it was in Arizona, where a father under the influence of methamphetamine chopped off his son's head in a car. It's this kind of aberrant and bizarre behavior. So I've followed this for a very long time. The frustration of not being able to do those things that can control it. The high majority of drugs that the pharmaceutical companies make, the fact that they're illegally used, to me, is just a stunning figure. It's high profit, I understand. That smurfing is such a profitable industry. I mean, somebody for $6 worth earns $30. At the end of the day, they've earned $100. So you can field teams of dozens of people that go out in Los Angeles and just buy this stuff, turn it in, get their money. It's a huge, huge problem. In any event, unless there are additional questions, I'm going to call up the next panel. Please, go ahead.
One comment. I want to read a couple sentences of a report that I've asked you to put in the record already. And all I can do, because I know how sincere each of my colleagues are on this issue, so about all we can do is bring out some facts for consideration. So I would quote two sentences from the National Consumer League. It's signed by Sally Greenberg, Executive Director, NCL also urges you to also consider the health and budget implications of requiring pseudoephedrine products to only be available by prescription. Prescription-only status would make it necessary for patients to consult with their doctor for common cold and allergy symptoms, raising health care costs for all consumers, and since these OTC products are not covered under Medicaid, forcing the most vulnerable patients to pay out of pocket for their medicines. I thank you very much, Madam Chair.
And I thank you, Senator. Gentlemen, let me thank you very much. I know you have other things on your schedule. It is very much appreciated that you appeared here today, so thank you again. And now we'll go to our second and final panel. Are you going to put the place cards? Okay. I will introduce the panel as soon as I get the... I'll begin with Linda Sudjum, who is the president for Consumer Health Products Association. That is a member-based association representing manufacturers and distributors of non-prescription over-the-counter medicines and nutritional supplements. Prior to joining CHPA, Linda spent 21 years at the FDA. At CHPA, she has overseen the establishment of an educational foundation whose goal is to promote health through the safe usage of over-the-counter medications. Keith Kane is the sheriff of Daviess County, Kentucky, and chair of the Narcotics Enforcement Committee at the National Sheriff's Association. Sheriff Kane's law enforcement career has included extensive experience in narcotics investigations, both in an undercover capacity and through casework. Next is John Kroger, the Attorney General of the state of Oregon. Mr. Kroger has devoted his entire life to public service as a United States Marine, federal prosecutor, public policy expert, and teacher. He's really covered the bases. As a federal criminal prosecutor, he won major cases prosecuting Enron executives, served on the emergency response team to the 9/11 terrorist attack. In 1999, he received the Director's Award for Outstanding Performance as an Assistant United States Attorney from Attorney General Janet Reno for convicting 2 mafia captains for committing multiple murders. Kent Shaw is the Assistant Chief of the California Bureau of Narcotics Enforcement. Assistant Chief Shaw has spent 20 of his 23 years in law enforcement devoted to narcotics enforcement. His career is specialized in methamphetamine enforcement, having investigated hundreds of meth cases and seized more than 100 meth laboratories. As the Assistant Chief of the Bureau of Narcotic Enforcement, he is responsible for the California Clandestine Laboratory Enforcement Program, the California Controlled Chemical and Substances Program, and California's Prescription Drug Monitoring Program. And finally, Gary Kendall, Director of the Governor's Office of Drug Control Policy of the state of Iowa. Mr. Kendall was the county attorney in Warren County, Iowa for 4 years. He worked as an assistant county attorney from May of '99 until January of '03 in the Drug and Gang Unit of the Polk County Attorney's Office, and from November 1996 until May 1999 as the drug prosecutors for the Warren and Marion County Drug Task Force. So that is our second panel, and it is a panel, I believe, evenly divided, so it should be very interesting. We welcome you, and Ms. Sudan, did I pronounce your name correctly? Welcome, and why don't we begin with you? If you could try to limit your remarks to 5 minutes, that would be appreciated.
Thank you. Thank you, Chairwoman Feinstein and Senators Grassley and Senator Wyden. I thank you for the opportunity to testify today. I'm Linda Sudjum, and I'm president of the Consumer Healthcare Products Association, the trade association representing over-the-counter medicines. I want to express our industry's commitment to working with you on this very serious problem of diverting pseudoephedrine to methamphetamine. Our goal is to stop illegal pseudoephedrine sales while maintaining the over-the-counter access for legitimate customers. Maintaining access to non-prescription pseudoephedrine is important because pseudoephedrine is unique, and for many consumers, it is the ingredient that works best for them. Pseudoephedrine-containing products like Sudafed, Claritin D, and Zyrtec D are used by 15 million Americans each year. Senator Feinstein, the Combat Meth Act that you authored has largely been a success in reducing meth labs nationwide. However, we all know that persistent meth cooks have been getting around the sales limits imposed by that legislation. To help stop illegal pseudoephedrine sales, today we are calling on Congress to improve the Combat Meth Act by amending it to require that all over-the-counter pseudoephedrine sales be tracked through an electronic tracking system. Basically, we're asking that the current paper system be modernized to provide a system that will actually enforce the CMEA sales limits, working seamlessly across all retailers and across all states. 10 states have already adopted this solution, passing legislation that requires retailers to use an electronic tracking system for pseudoephedrine sales. We are working with retailers in 8 of those states by funding the National Precursor Log Exchange, or NPLEX, which allows them to comply with these new laws. NPLEX provides state-of-the-art technology. For example, using sales records already required by the Combat Meth Act, electronic tracking has blocked already thousands of attempted illegal purchases. The system also generates useful electronic records so that law enforcement can more easily identify meth cooks. Kentucky law enforcement officials tell us that electronic tracking leads to 70% of their meth lab busts in key counties in that state. NPLEX can work seamlessly across state lines. The data collected is secure and by law is only accessible by the appropriate state law enforcement agencies. Law enforcement officials in many states, including the Louisiana State Police, the Illinois State Police, the California Sheriff's Association, the Kansas Sheriff's Association, and the Washington Association of Sheriffs and Police Chiefs are calling for the implementation of electronic tracking systems. NPLEX strikes the right balance between preserving pseudoephedrine access for legitimate purchasers while blocking meth cooks from accessing illegal quantities of the product. While 10 states have conducted and have concluded that electronic tracking strikes the right balance, Oregon adopted a prescription mandate. And Oregon has seen meth labs drop 98% from 587 in 2001 to 10 labs in 2009. But it's easy to draw the wrong conclusions from these numbers, because during the same period, Washington State, which did not have a prescription mandate, also saw meth labs drop 97% from 1,480 to 39. The fact is that the meth lab problem has dramatically abated in many states in the West without a prescription mandate. When contrasted with electronic tracking, prescription mandates simply fall short. A prescription mandate would be more expensive for consumers, sales limits would no longer apply, and there would be no system for real-time blocking of illegal prescription sales within states or across state lines. Prescriptions are a healthcare function, not an effective law enforcement mechanism, as is clearly seen by the widespread and growing diversion and abuse of prescription medicines. Having spent 21 years of my career as a senior official at the FDA, I believe that the placement of a medicine on prescription status should remain a medical decision rather than a law enforcement issue. This is especially true when we can meet law enforcement needs without burdening consumers. The bottom line is that a multi-state approach to electronic tracking of pseudoephedrine sales offers benefits for law enforcement with none of the prescription downsides for consumers or for our healthcare system. Electronic tracking is the key to effective enforcement of the Combat Meth Act. As an industry, we look forward to working with you on federal legislation to enable the nationwide deployment of NPLEX to provide one unified electronic tracking system across all states. Thank you for the opportunity to testify today.
And thank you very much. Appreciate it. Mr. Kane?
Thank you, Senator Feinstein, Senator Grassley, and Senator Wyden. I appreciate very much, as I sat in the back of the room and listened, the obvious concern, genuine concern that each of you have for doing something about this particular issue. We may not agree on how to get there, but we certainly agree on the end result. As a 36-year veteran law enforcement officer, I'm all too familiar with the destructive effects of substance abuse in general and methamphetamine in particular. Two, as the chairman of the National Sheriff's Association's Drug Enforcement Committee, I've had an opportunity to learn of the many varied and different tactics that, and initiatives that are undertaken by governments to reduce the latter, methamphetamine's traumatic tolls on our communities. I will tell you that as a Kentucky sheriff that I'm extremely proud of the fact that our Commonwealth was one of the first, as previously noted, one of the first states to require statewide electronic tracking of these cold and allergy medications that contain pseudoephedrine. Our electronic tracking program ensures that consumer purchases of these medicines are blocked at the point of sale. No matter where in the state those purchases are made. We now have a unique opportunity, as you've already heard today, to widen that net for controlling the sales of medicines containing pseudoephedrine. The Kentucky system is being expanded and offered to any state that passes appropriate legislation, providing statewide blocking and record keeping to states at no cost to local governments. That cost is not being borne on the backs of taxpayers. It's not being borne on the backs of state or local governments, but on the people that quite frankly and very candidly should be paying for it, and that's the pharmaceutical companies that produce these medicines. I'm excited that Illinois, Missouri, Kansas, Washington, Iowa, Alabama, and Louisiana recently joined this effort by passing legislation to implement similar electronic tracking. Our colleagues at the Illinois and Louisiana State Police have begun to implement the system statewide and are impressed with the system's ability, as Illinois State Police Master Sergeant Eric Hall said, to see across state lines. It's my hope that other states will soon follow suit. The system we use is effective, and it allows for real-time tracking and blocking sales to enforce the state and federal limits that have already been noted here today. E-tracking helps law enforcement officers find the smurfers that have been discussed. My colleague, Sheriff Frank McKeithen of Bay County, Florida, says his county's electronic tracking ordinance has significantly reduced smurfing and meth lab activity in his county. And in fact, the counties in Kentucky, the two most prolific counties in my home state of Kentucky, my colleagues indicate to me that the majority of the meth labs that they locate in those jurisdictions are the direct results of the intelligence garnered and gathered from our electronic tracking system. As more states join this effort, we will begin to block sales even more effectively, because not unlike Kentucky, other states' meth problems don't begin or end at the state jurisdictional boundaries. As e-tracking expands into more states, we will be better equipped to identify and incarcerate meth producers and block illegal sales across state lines. Now, some in my profession that you've already heard from say that requiring a prescription for cold medicines containing pseudoephedrine is the answer, Senator. And while, again, we don't agree on how to get there, we certainly agree that the key component in doing something about this problem is limiting the availability of pseudoephedrine. So how best to do it? Of the 12 states that have enacted new laws on this issue, only 2 states, of course, Oregon, Senator Wyden, and most recently Mississippi, while 10 others have passed electronic tracking. Though efforts to require a prescription for these medicines are well intended, I believe, in my professional opinion, they are misdirected. Know that I respect all of you, and I certainly respect my peers in law enforcement and fully relate to their passionate desire to fight methamphetamine. I've dedicated the bulk of the last 10 years of my career to combating this problem. Davis County, my county in Kentucky, had the dubious distinction for a number of years of producing the most illicit methamphetamine in our Commonwealth. But my experiences indicate to me that if we pass prescription, that our ability to control it, the distribution of pseudoephedrine and track it may actually decrease. Our ability to stop illegal sales at the point of sale across state lines, I believe, is the strongest control available. The disadvantages of prescription system include higher health care costs. We've heard that, but I don't know a lot about that. What I came to talk to you about today is a law enforcement perspective. And what we will see is we will fall victim, I fear, of the court of unintended consequence. We will lose that real-time sales tracking. No sales blocking. The electronic tracking system in Kentucky blocks over 10,000 grams of pseudoephedrine a year. That's 10,000 grams that are destined for meth labs in my state. And none of the previously mentioned limits, Senator, that you helped pass in the Combat Methamphetamine Act that have been so tremendously successful to us, those will go away. We won't be able to tell doctors how much of this drug to prescribe. And unfortunately, there will be physicians that we know that will take advantage of that. Indeed, currently, the fastest growing segment of substance abuse in our country today, Senator, and certainly in my Commonwealth in eastern Kentucky, is prescription drugs. For us to assume that we can prescribe and give prescription status to yet another drug and expect the problem to go away, I believe, quite frankly, is a pipe dream. I believe it's foolhardy. We can't control our Vicodin. We can't control our Percocet. We can't control our Oxycontin. And we expect to control pseudoephedrine by making it a prescription drug. My time is up, and I had so much more that I did want to say, but let me just say this. There are a number, it's just not my thoughts, but there are a number of law enforcement officials and administrators throughout the country today that agree that electronic tracking is the proper method in which we should try to control this pseudoephedrine. Arguably, I guess, as a law enforcement administrator, as a sheriff, one of the most important responsibilities that I have, Senators, is to provide my officers and my deputies with the resources, with the intelligence, with the information they need to not only effectively do their job, but to safely do their job. Electronic tracking, the meth check system does just exactly that. And I fear what would happen if we were to lose it. Thank you very much for your time, and I apologize for running over.
Thank you very much, Sheriff. Appreciate it. Mr. Kroger, I beg your pardon.
Madam Chair, in 2006, Oregon passed a law which required consumers to get a prescription before obtaining medicine that contained pseudoephedrine. That legislation has had three main results. Number one, it has virtually eliminated domestic meth labs in Oregon. Before the law was passed in 2004, we had 472 meth lab seizures in the state. In 2009, we had 10. So we've seen a radical reduction. There's been a question raised as to whether this is statistically significant or not. Let me give you two different comparisons. First of all, if you compare Oregon's lab seizures for 2009 with states in the Midwest or in other parts of the country, there's an obvious difference. Missouri, over 1,700 lab seizures. Kentucky, over 700 lab seizures. So there's a very real difference there between 10 and seizures in the hundreds. If you look at the West Coast, I think some of the confusion comes from the fact that the EPIC data that the DEA has is incomplete. So if you look at, for instance, the data that's been cited for Washington with 39 lab seizures in 2009, I confirmed yesterday with Washington officials, the actual number is 186. Mm-hmm. And the reporting, I can't tell you why the reporting has been delayed. I've been told anecdotally it has to do with budget cuts. But the Washington Department of Ecology says that the correct number is 186, which is a substantial increase over what they had in 2008. Again, in the West Coast, we have a more mature meth market than other parts of the country. We have a smaller number of labs that tend to produce more meth. So you do see a reduction in a lot of the western states as our meth market has basically been consolidated in California, where super labs produce a huge amount of the meth. But still, the difference between something like Oregon has with only 10 labs, quite frankly, those labs were fueled by pseudoephedrine purchased in Washington, Idaho, and California. versus what Washington has, 186 incidents in the same year. It's significant. The second big result is we've eliminated smurfing. And as Director Kurlikowski noted, smurfing is the big challenge in this area. And by requiring a prescription, we've eliminated that problem virtually entirely. And third, it's results. In 2006, the first full year where we implemented this law, property crime dropped 17% in Oregon. I can tell you as a federal prosecutor, as a law professor, you don't see numbers like that in the criminal justice field very often. That progress has continued. So in our latest numbers, both violent crime and property crime are down in Oregon significantly. Overall, crime is down over 10%. It's the largest single drop in the 50 states. It's very hard to disentangle why the crime rate drops from all the various causes. I can simply tell you that in the law enforcement community in Oregon, it's universally accepted that this legal change has overwhelmingly the biggest contribution to our drop in crime numbers. With respect to electronic tracking, I would simply ask the committee to look at the data in Kentucky, and with all due respect to my colleague, with a full electronic tracking system, they had over 700 lab seizures in this past year. I really don't want to have a large number of labs and a large number of seizures. What we want to have is a very small number of labs, and the Oregon model has done that. In terms of patient access, like the senator, I do a huge number of public appearances around the state, about 150 a year. I talk about this law at virtually every one, over 95% of those. I've never had a single constituent ask me or complain about not being able to get access to the medicines they need. And the medical community in Oregon, I think everyone universally agrees that the meth problem is such a huge public health problem in terms of its impact on citizens' health, on the impact of children that are exposed to this stuff, that it's a very good trade from a public health point of view. You know, it's true that we have a lot of meth in Oregon still. When the demand for drug is there, the market responds. Most of our meth now is produced in other states, particularly in California, where, as the senator's aware, the smurfing problem is horrible. That suggests to me that taking the Oregon approach nationwide and limiting access of drug producers to that pseudoephedrine will have a major, major, major impact on cutting off the source of supply. Thank you very much for allowing me to come and testify today.
Thank you, Mr. Attorney General. We very much appreciate you and others that have come long distances to be here today. So thank you very much. Mr. Shaw?
Good morning. Can you hear me? Okay, sorry. Well, good morning, Senator. I really appreciate this opportunity to discuss this very important issue with you. I think probably one of, if not the most important law enforcement issue facing us right now in America. And as you all know, California is, unfortunately, still remains to be the epicenter of methamphetamine, having battled this personally for, well over 20 years back when it was a fairly obscure drug, really only focused to California. We warned our colleagues for many years that this scourge is going to be sweeping across the nation, and unfortunately we have witnessed that take place, and that sweep continues to this day. And make no mistake that not only in California but elsewhere in the nation, in my discussions with folks and my affiliation with the National Meth and Pharmaceutical Initiative, is that prescription or pseudoephedrine diverted from retail outlets is the sole source of pseudo that is being used as the essential precursor to make methamphetamine. So that's an important distinction to make. And the Combat Methamphetamine Epidemic Act was a very important piece of legislation that came out and had some profound impacts, but unfortunately, as we know, it had some loopholes in there. And we wanted to find ways to fill those holes, and we thought that electronic tracking early on was going to be a good, viable solution for that. And as you mentioned earlier, that we estimate in California that approximately half of the pseudoephedrine that is being purchased at retail outlets is being diverted for methamphetamine labs, which is a pretty staggering number. And if you look at the...
You stand by that figure?
Yes, and obviously that's anecdotal. We can't get the information. We've tried from the industry. They claim that it's proprietary. I had a meeting with industry folks from Johnson & Johnson, Shearing Plow, as well as the Consumer Healthcare Product Association in June of last year in the midst of our bill after we had passed in the Senate. And I threw those figures out during that meeting. And the response to me, I'm paraphrasing, was the effect of, we really don't know what those numbers are. We can't prove what they are. You're the experts on that. We can't dispute it. But I looked at the example of this 5-gallon bucket up here, which was seized in a Central Valley lab in California, which is filled with a variety of different products of pseudoephedrine. If you think about how long it would take 100 families of purchasing and using properly pseudoephedrine to fill that bucket, it would take years. However, that only takes a handful of Smurfers a month or two to be able to fill that bucket. So we're talking about a small percentage of those who are actually purchasing the pseudoephedrine who represent a substantial portion of that market share, those who have huge purchasing amounts of that. That's what we're contending with. And when you look at examples, as you cited in the letter that you had regarding the 11 stores that we looked at, the CVS example, that was a 90% reduction. That was just 11 random stores in LA when the block sales system went into place. And of course, at the corresponding time period, we had huge amounts of Californians that were flooding over to Nevada to make purchases over there at the same time. Those were Smurfers. Those aren't legitimate customers that are doing that. At the same time, one would think, well, that's wonderful. This system obviously has blocked a lot of sales. In the case that you cited, it was 16,000 grams, enough to be converted into 4 pounds of methamphetamine. The problem is that just as the CMEA gave birth to a cottage industry known as smurfing, the block sale feature, which we all agree is an extremely important component of electronic tracking, is what gave birth to the next level of sophistication in smurfing, and that is false identifications. And early on, when we started using the meth check system in California, we found some utility in it. It actually had people in there who were going out and buying large amounts. We had no problem using their identification to do it, and we were able to use that, as labor intensive as it was, to actually do some investigations. Now, granted, we were only scraping the surface because we couldn't begin to deal with the volume of the smurfing that was there with the resources we have. But unfortunately, when the block sale system came into place, the Smurfers immediately adapted to false identifications, and they have now rendered that system completely useless. This right here is the exceedance report for meth check in California for the month of March. 100 pages of documents in this. I gave this to our analysts in preparation for this thing. Their response to me when they handed this to me, I quote, "utter garbage," is what this contains right here. This is full of nothing but false identifications, misprints of the information that was removed out of the system that contained driver's license, which in California require an alphabetic number and then numbers after it. Many of these contain nothing but one letter. Many of the names are one initial. The addresses are listed, if they're listed at all, are listed as 1, 2, 3, 4. There's just a lot of bad information that goes into it. This is not actionable intelligence that we in law enforcement can use any of this information to do anything with. And that's what the system has been rendered with. And I can tell you that the crooks in California are no more sophisticated than they are anywhere else. This is something that will be perpetuated if this system is put wherever it goes. So this comes down to an issue of prevention versus reaction, and that's what these two strategies are. The Oregon example clearly is a preventative measure. The other one is a very costly and reactive measure that requires a lot of reinforcements to do that. You've heard a lot of mention about other states that are pursuing electronic tracking. The reality is that's been a fallback plan in many places. That's exactly what's occurring in California right now. We tried to go with prescription only. The California Sheriff's Association was mentioned earlier as being in support of electronic tracking. You were in the meeting just recently with them when they recommitted their conviction that prescription pseudoephedrine is the way that they want to go. This is a fallback plan that they're trying to do. They figured it's better than doing nothing, and just marginally at that, I will add. So that's what the issue is. And if you look at what electronic tracking is at its very best, it's incapable of preventing smurfing of legal purchases by folks, because those will not be blocked and those will not be denoted as being exceedances. Those are not information that will be put out to law enforcement. But unfortunately, at its very worst, as I mentioned earlier, the false identifications has rendered the system completely useless in terms of what we had. Well conceived, greatest intentions when it started, but unfortunately today we have the modern version of snake oil. That's essentially what this system is going to perpetuate if we put this forth. And we are not in a position to be able to do that and carry it forth. And you talk about Kentucky being the gold standard, and very admirable for them to take the lead on that and to try something that all of us were looking very optimistically to follow through with. The unfortunate reality is, as you've heard the numbers, last year a 61% increase in the amount of meth labs in the state of Kentucky. My colleagues in speaking with in the state of Kentucky, including the Kentucky State Police, who manage the entire system rather than individuals at certain individual counties' experiences, tell me that The results of their study of those seizures the meth check system has resulted in only assisting in the seizure of 10% of those labs, not 70%. So 61% increase in labs, a system that has allowed that to take place, yet is only assisting in 10%. And I'm also told that some of that percentage is a result of only assisting law enforcement after the labs have been seized under traditional law enforcement methods, and they're mining the data out of the system to then support the prosecution. So to me, that doesn't indicate that there's any kind of a success in that system, and that's not something I could in good conscience go to the members or my citizens in my state and put forth a system that I think there's overwhelming evidence of.
Thank you very much, Mr. Shaw. Appreciate it. Mr. Kendall?
Good morning. Ms. Chairman Feinstein and Ms. Chairwoman Feinstein and Mr. Chairman.
Whatever, Chairman is fine.
Grassley, Senator Wyden. It's really my pleasure to be here this morning on behalf of the state of Iowa to be able to speak with you a little bit about our perspective on the implications of making pseudoephedrine prescription only.
Could you pull the mic and
Sure.
speak directly into it?
It's our position, thank you, it's our position in Iowa that we would like to give the electronic tracking system an opportunity to work or not work. We were just, last legislative session, we were finally successful in passing the legislation that would allow us to implement MPLEX on a statewide basis. We'd had a couple pilot projects that we had some success with in a couple of counties, and we were real pleased to finally be able to get that legislation passed, and I think we're in the home stretch of actually getting it, the system up and running in our state. And really, I don't disagree with a lot of the comments that have already been said as far as the factual basis. I think you can't say that for sure making it prescription only was the only thing that caused labs to decrease in the state of Oregon. I don't think it's not unlike Iowa. We have a real strong presence of the Mexican trafficking organizations, and I think the supply and demand of the Mexican meth and the purity, the availability, the cost, all those things are tied together. And I think these meth users make the decision. At some point, the purity falls, to the point where they think, well, I can make it, better than that, and it's worth the burden of going around and trying to collect these tablets and go to the effort and pay the people to do this. And so I think there's a lot more factors in play than just one silver bullet, and that's what concerns me about this. Is I don't think that making pseudoephedrine prescription only is a silver bullet to reduce meth labs. I think based upon our experience with our prescription monitoring program, I think the sheriff mentioned it, with regard to other prescription drugs like the painkillers like OxyContin, I think that's proven really that we have our own challenges in regulating and controlling access to those prescription painkillers. It's my belief that if we make this a prescription only, you're going to see a diversion. It's prescription diversion. You're going to see that with regard to pseudoephedrine products. Mexico went so far as to ban this stuff completely, and they still have meth labs. So, to have this presented as a silver bullet that's going to, reduce or get rid of meth labs in every case, I don't think is a fair presentation of it. I think it's admirable that what Oregon's done, and I take nothing away from them at all. I've been involved in this position for a number of years and have been exposed to the results that they've had on a number of occasions. And I think it's great. From Iowa's perspective, we'd like to try the electronic tracking system. We don't have a very good, in my opinion, prescription monitoring program in our state. We have, it's not mandatory participation. So doctors and pharmacists don't have to even look it up or put the information in. We also have very restrictive law enforcement access. So if you stick this in the prescription drug category without making some kind of arrangements for strengthening prescription drug monitoring programs like the ones in Iowa that aren't as strong as they could be or should be, in my opinion, I think you're just going to drive this underground, and it's going to make it much more difficult for law enforcement to apprehend the labs that are out there. And when we all know there are labs in our state that we don't find, the numbers that get reported are the ones that are found. And I think the sheriff from Kentucky pointed out also that, a lot of the ones that account for the increase in their their lab totals were found because of this system. And those are labs that, you know, presumably those people were prosecuted and sent to prison, and they're not making meth for at least as long as they're in prison. So there's some good that is made happening in these states from these electronic tracking systems. And I would submit that we really haven't done the electronic tracking on a widespread basis successfully or not. I mean, I think we need to give it an effort. The industry has stepped up. You know, I'm not naive enough to believe it's out of, you know, total benevolence, but they've stepped up and they've offered to pay for this system. They've offered to make it statewide. We're going to be able, and actually nationwide, excuse me, we're implementing, Missouri's implementing, Illinois is implementing, Kansas is implementing the same system. So I think once we get that up and running, and hopefully some other border states will be in a position to implement this system as well. And I think that's going to really severely restrict people's access to pseudoephedrine, and it'll help us in our continued battle against meth labs. So thank you.
And I thank you, Mr. Kendall. Appreciate it. I think this has been a really interesting panel. It's about evenly divided and all very respected people. So we very much appreciate that. Sheriff Kane, let me begin with you. I don't know whether you know this or not, but the Kentucky Narcotic Officers Association have written us a letter dated April 8th, signed by their president, saying they very much support making these products prescription only. And as part of this letter, here's what they say. The Kentucky electronic tracking system is accessible to Kentucky law enforcement agencies for tracking the sales of PSE. However, despite the new electronic tracking system, Kentucky's 2008 Clan Lab response numbers rose to 428, up from 302 in 2007, an increase of 41%. In 2009, Kentucky experienced a 74% increase over 2008, with a total of 743 Clan Lab incidents. In the first year of operation, June 08 through May 09, the electronic tracking system blocked 18,000 sales of pseudoephedrine. However, the tracking system had basically no impact on the number of labs. And I gather the membership has voted, and it's 300 strong, and they come out with the view that it is really only making these drugs prescription only that's going to work. Would you like to comment on that?
Oh, yes, ma'am, I certainly would. I am very much aware of the Kentucky Narcotics Association's position on this. Those individuals are colleagues of mine. I've worked with them for a number of years and have a tremendous amount of respect for them, Senator. But I believe they're in error. Certainly those numbers can't be disputed, nor would I try to dispute them. But I do think that we need to look at exactly what they might mean. I recall, as I indicated to you, we've been very engaged and very involved in this across the Commonwealth on both the state and the local levels for a number of years. And I can recall when we first saw those significant reductions in meth labs, 50 to 60% in 05 and 06 as a result of initiatives such as your own. And my colleagues, many of them in the Kentucky Narcotics Association, championed these limits and championed one particular initiative with regards to being the panacea that was going to solve this problem. I myself, as did a number of other individuals in my profession, cautioned against that. Methamphetamine is just too complex to affix a simplistic and simple solution to it, raise the flag and expect a victory and go home. What I think has happened, and the reason that I mention that is that I don't think any more than we could affix our successes at that time on one particular initiative. It was a long-term, multifaceted approach to what we did that we started to see those results. But equally disturbing is that we look at one particular initiative and affix to it the failure of the system, which is what is being done with the meth check, quite frankly. It's being utilized as a scapegoat. The meth check system has been phenomenally successful. I know this because my officers work with it every single day. It's the two-edged sword. It denies sales at the point of sales and provides that intelligence to our officers in order to do it.
Let me, you think
sorry.
it's been successful. Now, let me just ask Mr. Shaw, everything in California is unsuccessful. There is no tracking system that can work, I believe, nor does the law enforcement community believe it can work. Mr. Shaw, why do you believe that is so?
Well, that's simply based on our experience of using the system. Now, granted, in California, we don't have, it's not a comprehensive system where every one of our outlets and pharmacies is linked on this system, but we do have two of the largest retail distributors or pharmacies in California that do use the system, and we've been using the system for several years prior to the block sale component being placed in October of 2008 and right up to this very day. And we've seen the progression of this thing go from having some utilitarian aspect to now essentially being rendered completely useless for what we're trying to accomplish here and as an investigative tool. And if one thing I have learned in my years of experience in this whole issue, and if you look not only to the meth check system, but even to Tennessee, who has a completely separate tracking system that's based on an intelligence-based, their numbers are going through the roof as well. They're seizing more labs and they're arresting more people. And I think I speak for all of law enforcement when I say we don't want to seize more meth labs, we want to prevent them. And we are never going to arrest our way out of this problem, and we're never going to seize our way out of this problem. So to put a system into place that's going to burden us even further to go out and try and react and catch these people rather than preventing it in the first place, to me just seems like failed policy.
See, this is the hard part. Now, Senator Grassley is a very strong and positive proponent of any cause he chooses to take. And it will be, well, this is going to cost the consumer more. The consumer is going to have to get a prescription. I see the arguments that the pharmaceutical industry is going to make. And yet, on the other hand, and you know this, I have tried and tried through bill after bill after bill to find a way to solve the problem, and it just is getting worse. And I don't know what to do, Chuck, other than to say, let's put it behind the counter, let's make it prescription, because it takes too much law enforcement time, and the drug is too powerful. You just can't ignore it. So you could take the whole LAPD and you couldn't stop it in Los Angeles. So, and this goes, bill after bill after bill. We've tried, we find a loophole, we plug the loophole, we go to the next thing. And here we are. So, if I didn't think the drug were so damaging to people, I might say, okay, let's continue with tracking. It isn't worth it, but we've got to stop it because of the damage that methamphetamine does to individuals.
I've worked with you to plug every one of those.
Yeah, I know you have. If you,
okay.
I mean, it's just very, and yet it's going to be a battle royal. And let me ask this last question, then I'll stop. How much will law enforcement stand up if we try and do this? Because the support would come from law enforcement.
I think very much so. Has been my experience, and I think even that continues to go. Those who cling on to hope that electronic tracking may offer some hope, I think that's dashing daily, and I think more and more folks, and in addition to, as you mentioned in Kentucky, in addition to the Kentucky Narcotic Officers Associations, there's 15 other law enforcement organizations within that state that are supporting prescription Sudafed, and that number is growing daily because the evidence is clear.
What do you do about the 14 or 15 states that don't have the problem?
Well, I think this is an issue of the greater need. This is too significant of a problem, and rest assured, those states that don't have a problem are the same ones that 20 years ago I warned didn't have the same problem we're talking about in Missouri, Kentucky, and everywhere else. It's on its way, and if we fail to do something about this issue, rest assured we'll all be reassembled here in another year or two talking about the same issue all over again, because all electronic tracking is going to do is a status quo. It's going to perpetuate this human misery even further, and it's going to come to states that don't have it.
Thank you. Thank you. Senator Grassley.
I'm going to have to submit some questions for answer in writing. so I'm only going to probably be able to ask 5 minutes of questions. So I'd appreciate anybody who gets a question for answer in writing that you would respond to us. I'm going to start with the sheriff. Your testimony states that electronic tracking systems are not only a law enforcement tool to catch those who commit crimes, but also a preventive tool. Some who oppose the electronic tracking systems argue that it merely continues to chase and does not prevent. First question, the number of meth labs appears to be up. Now, is there a difference in the types of labs we count today versus yesterday?
Yes, sir, and that may be, alludes to Senator Feinstein's question earlier, Senator. There's a relatively new, at least in my part of the state, method of producing methamphetamine called the one-step or the stew or the one-pot, which takes a very, very simplistic procedure and makes it even more simpler. This is one of the reasons that meth labs have proliferated. Also, we put a great deal of emphasis on the last decade in law enforcement in Kentucky of reporting these. So certainly there's more of these labs being reported than they were at one time. But the primary reason, Senator, that I believe that those labs are up in response to your earlier question, is because the aggressive and proactive nature of law enforcement that utilizes the tool of electronic tracking. Those numbers are up because we're finding one of them. My colleague from California indicates he wants to stop labs as opposed to finding them. I don't know of any other way to stop them other than to find them and to prosecute and hold accountable those people responsible. And that's what e-tracking does. And that's why I'm so passionate about the fact that if we lose it, law enforcement will begin to operate in the blind, in the dark. Sure, meth lab numbers will go down, but meth labs will continue to proliferate.
I have a second question for you. General Kroger testified that Oregon has had success reducing meth labs while states like Kentucky have not. Do you agree with the assessment, number one? And number two, why has Kentucky not had as much success in reducing the number of reported meth labs compared to Oregon?
Well, Senator, I think I probably just answered that question. And, I've been asked a number of times in connection with what California is doing, what is Oregon doing. And quite frankly, I don't feel qualified to speak to you in terms of that. If this is working for Oregon, God bless them. I'm glad. But because of all the reasons I've stated and a number of more that I can submit in writing to you, I'm convinced that the tools that we need, the resources that my officers need, are the ability to see across those state lines, to communicate with each other, and to utilize this system. If we lose that, again, we operate in the blind. The lights go out.
Okay. Gary, Iowa has a number of communities that straddle borders such as Quad Cities in the east, Sioux City and Council Bluffs on the west. If states bordering Iowa implement real-time tracking systems similar to our state, will the systems be interoperable to ensure that Smurfers cannot circumvent the system by leaving the state?
They will be. I know the three states that I mentioned earlier, Missouri, Illinois, and Kansas, are all looking at Implex, which is the same system that Iowa is using. So those certainly will be, and I think Implex is designed to be interoperable with other reporting systems like that.
Okay. The Iowa law does not require pharmacists to serve as law enforcement and block sales to individuals the system alerts them to. However, the law allows them to refuse the sale if they choose. Was this flexibility important when trying to get the support of the industry and all interested parties?
It was in Iowa. That was the only way we could get the bill passed, quite honestly. My perspective has always been they have that's their job anyway. They deny sales of OxyContin and forged prescriptions and those types of things, but we had to concede that to get the bill passed. I think an interesting development since we passed our legislation, though, there's been some civil fines imposed on, I think it was Rite Aid, by the Department of Justice, and that's really kind of changed the mood in our state, at least, of the pharmacists. They're more embracing of the stop sale component. I think they're looking at it as kind of maybe a backup for them to protect them from possible civil penalties in the future.
Yeah. Mr. Shaw, you stated in your testimony that Oregon law resulted in an annual increase to the state Medicaid program of $7,780. Is it your understanding that this is the total cost of the Oregon Medicaid program?
As it was reported to me in a document that was provided, yes. And then I think they also mentioned in there that that cost was far more offset by the other savings that they received in current terms of social services and law enforcement. So although that was the total cost they listed, they felt that that was dwarfed by far greater savings.
The letter from Oregon that you cite in your testimony makes clear that this is only the cost of the medication. A follow-up, given to you, Mr. Shaw, given that the Department of Justice report makes clear that the Oregon law has caused local meth production to be supplanted by Mexican ice meth, and local reports indicate there's more meth on the street now than before, it's important to make sure that we have all the facts straight before any such step is considered nationally. Have you taken into consideration the cost to seeing a physician, taking time off from work to do so, and especially the impact that this would have on lower income families that might have the same access to a doctor that you and I might have?
Absolutely, and I gave this thorough research proposing our legislation last year in California, and of course I looked to Oregon for the experience they had at that time, which had been approximately 3 years of what they had. And that was careful consideration we gave, and those are some very poignant questions that I received from our legislatures in California that were concerned about that. And I think the evidence, again, has been overwhelmingly clear, is that there was no adverse impact to the uninsured or the homeless from the information we received in Oregon. The same was true from the emergency room physicians in Oregon, who said that the uninsured did not flood the emergency rooms, that the doctors are not overburdened, and the reason that the pharmacists have overwhelmingly supported it is because it frees them up to do what they need to do, to deal with patients and not have to be the police to deal with who they know were the end of the supply of Smurfers that were coming in. So gave it very careful consideration to look at all of those issues, and as was pointed out by Senator Wyden earlier, the parade of horribles. And quite frankly, I compiled empirical data to support, to refute all of those, and yet the opponents to the bill never provided anything other than expensive ads that were put out to put that forth.
Okay, Dr. Linda, we've heard a lot today from law enforcement, but we also know that industry will be deeply impacted by any effort to make PSE prescription only. I'm concerned what this means to the cost of our healthcare system and to individual consumers. Testimony we've received from the National Consumer League that I quoted in part, that prescription would only create new financial hurdles for consumers, especially low income. In your estimation, what costs can the consumer of PSE products expect if PSE is scheduled nationally? What additional burden would be placed on manufacturers of PSE and retailers if PSE is scheduled nationally?
Well, I'd like to answer in detail to that, Senator Grassley, for the record, but I think you know very well that the cost would be would include all of the visits to doctors. It would include the cost of the prescription medication, probably because the insurance companies wouldn't pay for it even if you were insured. And it would require people to take time off work to get a prescription. But that's really not the reason we're opposed to prescription. We're opposed to prescription mandate for this product because it won't work. I mean, it's very clear that RX systems can be abused and RX drugs can be diverted. We see that all the time. The growing abuse of prescription opioids continues to be, in fact, the most growing substance abuse problem in this country today. And what we're hearing, and as Sheriff Kane has said, from law enforcement is that this will provide us, if you have an electronic tracking system, it will provide you with the information you need. If a law enforcement will not do that, I mean, it will not, the prescription system will not do that.
Okay. Question for Gary. Drug diversion is one part of the growing use and abuse of prescription drugs. In fact, prescription drug abuse is the fastest growing drug problem across the nation. Your testimony discusses the experience across the country with the diversion of OxyContin and prescription painkillers. If PSE products were to be labeled as controlled substances, is it your opinion that diversion of PSE would occur to produce meth?
Absolutely. These folks are very resourceful, and they adapt to, as has been mentioned a number of times, whatever legislation gets passed, they find the loophole. It won't take long for them to figure out that they can do the same thing that's being done with OxyContin and other prescription painkillers. And I think there's real, as the sheriff mentioned, it's real concern that drives it underground. law enforcement has less intelligence, and then you bring in the whole Medicaid picture, and these folks, who's paying for their doctor visits, and the last bill I saw or heard about, the last version of the bill had them having to see a doctor every 3 months, and that's a pretty significant expense.
My last question, and then I'll yield back whatever time I have. What would, for you, Gary, what would be the impact of making PSE prescription only in Iowa?
I think we'd probably see more labs. I mean, than we have now. We're finally poised to be able to track the folks that are purchasing illegally and be able to apprehend and prosecute them. And if you make this prescription only, you put it in another system that law enforcement doesn't have access to, they're just gonna keep on going, and we won't have any intelligence to follow up with them, and it's going to go back to the days when we just stumble across the labs or we get citizen complaints, and that's how we do our policing, and that's how we find our meth labs, instead of being more aggressive in the investigative side.
Thank you, Madam Chairman.
Thank you very much.
To both of you, I look forward to continued dialogue.
I do as well. Thank you very much. Senator Wyden.
Thank you, Madam Chair. And Senator Grassley, I know, has got to go to another program, and I want to make sure that he understands how much I enjoy working with him, whether it's this or Finance Committee. Just know that we'll be working very closely together.
Hope springs eternal.
Hope springs eternal. Let's review where we are 2 hours into this, because I am struck by how much this resembles the debate we had in Oregon. And General Kroger, I know, can testify the kinds of hearings. What would happen is law enforcement people, as we've heard in many respects again today with General Kroger, Mr. Shaw, come in, talk about why this is important, why the current systems haven't worked, and opponents come and advance what I call the parade of horribles about the extra cost and the inconvenience and the like. And in Oregon then, as we have sought to do today, we ask for hard evidence from the opponents, hard documentable evidence indicating that there would be problems if you go with the Oregon system. And they say, when we ask about one particular problem, they say, as Ms. Sudam just said when we asked about cost, she said, well, that's not really my concern today. My big concern is something else, which was the illegal kind of diversions. So I would just ask, as we leave today, that we continue to insist on hard, documentable facts as we get into this discussion. And what is now on the record that is hard and documentable is that the director of the Office of National Drug Control Policy has told us, A, he believes problems with electronic tracking, in his word, are legion. So he has made it clear what he thinks of the approach that's being advocated in Kentucky and by the pharmaceutical industry. And he has said there is no reason, based on his analysis, why the Oregon model wouldn't be successful. So those are hard facts on the record. I want to get into a couple of other areas where I think we can, again, have a debate about facts. Now, Sheriff Kane, you said on one of the key issues, the use of false IDs for smurfing, something that I think requires further analysis. You said, you asked, won't criminals use the same false IDs to obtain prescriptions for PSEs? Now, I listen to that and I say, sure looks to me like convincing a doctor to write a prescription based on a false ID is very different from somebody who's interested in criminal activity from presenting a fake ID to a store clerk at Walgreens. Do you disagree with that?
I wouldn't disagree with that, no, sir. But certainly I think that there is ample opportunity, as is demonstrated by people that doctor shop, obtain these prescription drugs by fraudulent use, and all the other aspects of what we deal with in the escalating problem of the abuse of controlled substances in our communities. I don't think
General
that would go
Kroger,
away.
have we seen any evidence of that in Oregon?
Senator, I asked that question yesterday of our team of experts on this, and the answer is that we don't have a single documented case where someone has gone to a physician and tried to obtain pseudoephedrine under false pretenses or using a fake ID.
I appreciate your clarifying that, General Kroger, and I want to be respectful, Sheriff Kane. I just think it is preposterous to say that the likelihood of physicians writing a prescription based on a false ID as part of a diversion strategy is the same thing as getting all these criminals who are presenting these false IDs. And I don't say that in a disrespectful way. I think that is based on the facts, and as General Kroger outlined, he has followed up on that. And I just don't think that the facts come close to suggesting it. Just a couple of other questions, if I can. Ms. Sudan, I'm anxious to work with you all. We've worked with you on a lot of issues, the health reform debate in particular. Give me your assessment of the point that Mr. Shaw made. Mr. Shaw made the point that electronic tracking in California has failed to prevent large volumes of PSE from being purchased by the smurfing rings. Do you have any, again, hard evidence to suggest that Mr. Shaw is wrong?
Well, I certainly think that Mr. Shaw probably has the information that he has, but what I would suggest is that what would point out to you is California does not have a comprehensive electronic tracking system across the state. And therefore, what he's seeing is, in a very limited way, a system that's only tracking in certain stores. So you've got a very limited system in a pilot project in LA. This is not the same as an electronic tracking system across either the state or, in fact, across the country. I mean, what we can see from the advantages of electronic tracking is that the more states you have engaged in this, which is why we're proposing a federal electronic tracking system, you will have a greater coverage, and you will not have people moving from state to state to try to go around the system. In addition, if you choose to amend the Combat Meth Act, you will, I think, be able to deal with the false ID issue. We know that under the Netplex system, we will be able to identify false driver's licenses by directing back to against the state databases. And so you would, again, be able to find out people who are trying to game the system. The system continues to be evolving, it continues to get better, and I think the more states we have engaged, the better the system will be.
Madam Chair, this has been an excellent hearing. We've had thoughtful people on both sides of the issue. I just hope as folks walk out the door, they will reflect on the comments of Director Kurlikowski, because this debate has gone on for a considerable length of time. The states that are pursuing electronic tracking systems are seeing their labs go up. They are seeing a significant increase in the criminal activity associated with it. Oregon stands, as Director Kroger and I, as the one place apparently in the solar system that has gone to an approach like this. And when you look at the counter arguments in each one, those arguments were made in Oregon. They have not been shown to be reflected in the facts, and I look forward to working with you, with all of our witnesses, and I hope that given the extraordinary record you've had, Madam Chair, on this meth issue, that as we keep plugging, so to speak, we can plug what I think is the most significant loophole out there today, and that is that you cannot, in most parts of the country, take advantage of a system like Oregon's has, and Oregon has made a difference. So I look forward to working with you.
Thank you. I look forward to working with you, as always. And let me please thank our panelists. Again, you came substantial distances. It is very much appreciated. I hope you would feel free to weigh in with us with your thoughts as we try to assess where we should go with this, because, you know, if you have 14, 15 states that don't have the problem, Mr. Shaw said, well, it's the greater good, and I would agree with that. it also becomes very, very difficult to pass a national bill when you have 30 senators that say, I don't want to be I don't think my state is affected by this. So, I mean, that's just a realistic problem out there. I would like, Mr. Shaw, if I could, to get a better grasp of what exists with respect to the electronic tracking system in California and what does not. And perhaps you would have some thoughts on if that were the way that we went, what we should do to plug the loophole once and for all. I think I think it's very helpful having the Attorney General of Oregon here. He made the good case. I think his comments were very germane and on point and very helpful, and yours as well, Senator, as always. And so let me thank our witnesses, and the hearing is adjourned, and the record will stay open for 7 days.
2 hours.
Oh, thank you. That was interesting.
Sure. Yeah, let me get up here. It's a pleasure.
Got to.